On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals, Incorporated.
Here we are at the ACC annual meeting in Washington, D.C., and the late-breaking clinical trials continue to roll out. Probably one of the really important ones is the Corevalve trial, and I'm here with Mike Reardon from Houston, and Mike has just been part of this trial. Mike, this is not exactly the extreme risk, but very high-risk patients. Tell me about the trial.
Well, that's correct. So it was a randomized two-arm trial going to surgery versus aortic valve replacement using both transfemoral and alternative access. And we were shooting for a patient risk population of 15%, but like the partner trial, we missed. It's hard to get to 15% with modern surgery. But we got an STS of 7.5%. Our mortality was less than that. It was an OD ratio of 0.61, so our surgeons did a really great job. And the primary endpoint was to look at all-cause mortality at the end of 1 year with strokes.
So let me go back to the surgical issue, because that's an important part of this as well. The 30-day surgical mortality in this trial is roughly 5%, give or take. Fair enough?
Correct.
Well, that's an extraordinarily low number considering that these are high-risk patients. Does that have a bearing on the outcome of the trial? And I guess I should ask you, what's the outcome of the trial?
Well, the outcome of the trial was we now have our first trial showing superiority in survival at 1 year of TAVR over surgical valves without increased risk of stroke. So that's kind of the take-home message from the trial.
And that despite the fact that surgery in this group of patients really was sort of surprisingly good, is that right?
Well, much like the partner trial where they had an OD ratio of 0.68, your surgeons and partner did great. We had an OD ratio of 0.61. The surgeons did really great. Both trials, they chose very experienced centers and surgeons that do a lot of aortic valve surgery. So not surprisingly, we got good results, but the fact that it was about half of what you expected in both trials, really amazing results from the surgeons.
So at the end of 1 year, Corevalve beats surgery, if you want to look at it that way. Tell me what you think is going on. What's the basis for this, Mike?
Well, I think when you look at treating patients with severe aortic stenosis, whether you're going to do TAVR or surgery, the first thing is the insult of surgery to their physiology. These are older, frailer patients. Frailty was one of the things we selected on. We know in surgery that frail patients have a hard time getting over surgery. We have very good anesthesiology, very good care. These patients often make it out of the hospital, but sometimes they're just too frail to recover and they die over the period of the first year. TAVR does not subject them to the same level of physiologic stress, so not surprisingly, we even saw this in the partner trial, the early results kind of favored TAVR. They did better. But there the curves came back together. The interesting thing here is the curves never come back together. They stay parallel beyond 6 months. So you have an early benefit from the lack of insult using TAVR, lack of physiologic insult, and then they continue to get better. My personal speculation is that the paravalvular rate was fairly low, and it gets better in time with this valve, so it doesn't have an effect on mortality, and that may be why the curves never come back together.
And stroke rate was low as well.
Well, stroke rate was very low. The interesting thing is, of course, we knew that stroke was going to be a big question after the partner trial, and partner, of course, you look back at strokes retrospectively. The FDA said, listen, we're concerned about stroke. Everybody got a modified rank, and everybody got neurologists to see them, and so we looked a lot harder for strokes. Now, we actually found more strokes in our surgical population than they did in the partner. Not surprising. We have a lot of data that shows that when you look harder, you find more.
Okay, so TAVR has moved forward. We're now in, 5 to 7 years out with TAVR. What's the take-home message from this trial? What do you think the docs out there who are referring patients for TAVR need to know from this trial?
Well, I'd say this trial shows us that in the patient population that we selected, which basically matches the STS of the TVT registry or what we're treating in the U.S. today, with the Corevalve, the 1 year survival was superior without an increased risk of stroke. I think it moves our whole community forward.
Thank you, Mike. Really appreciate it.
My pleasure, Peter.